Hey guys, this is Ms. Coates, and we're going to go over nutrition. Um, bring up the PowerPoint. We're going to talk about nutrition, exemplars. We're going to talk about peptic ulcer disease, GERD, gallbladder, talk about obesity and bariatric surgery. We'll also discuss a little bit about EGDs versus colonoscopies. So the concept of nutrition. Think about it as we're going to talk about kind of upper GI versus with elimination is going to be your lower GI. So it's the process of nourishing or being nourished. I'm not going to read this to you, but you can kind of look through that and see what we're talking about with nutrition. So if you think about the upper GI system, we're going to talk kind of about the stomach, the esophagus, going down into that duodenum. And this is where you're going to get a lot of your digestion and absorption. And then when we talk about the lower GI, you're going to get into that elimination type information. So just a little bit of facts here. Peptic ulcer disease, you kind of got your older population, both men and women equally. GERD, a lot of people have GERD these days. Obesity and cigarette smoking, which I believe smoking is on the downturn, but it used to be you saw everybody smoking. So a lot of people do have GERD these days. Gallbladder disease, I want you to remember the 4 F's. So you're talking about females, and we don't mean anything bad, but just to kind of include the F, you're talking about fat females that are 40 and over and they're fertile, which means they haven't hit menopause, right? Usually those that have had kids before and things like that. So a lot of times we see those that are having that gallbladder attack, they're going to be female, they're going to be overweight, they're going to be 40 and older, and they're going to be still within their fertile stage. Obesity. I believe the whole world I know is obese according to these scales that they hold us to, right? US still remains the highest in the world. I know I used to talk to some of my past clinical students that were from different countries and things, and it just floors them when they come over here at how much food we sit down in a plate and what is available to us, whereas they're limited in other countries. So I wonder why we're all obese, right? Just some typical labs that we're going to kind of be on the lookout with peptic ulcer disease, pancreatitis, liver issues, malnutrition, all of that. I want you to know these labs. Now, these may be a little bit skewed from book to book, but just know that when we're going to put labs on a test, they're going to be really out of range. You're really going to know that this lab is either elevated or decreased. So we wouldn't put like AST of 36. No, if it's 36, you're still within that normal range. So you'd probably be looking at an AST or an ALT of like 60, something really abnormal. So I'm not going to read all these out to you, but just know, like with your liver dysfunction, and we'll go over this as well when we talk about hepatitis, that's going to be your AST, ALT. Of course, we all know bilirubin with the jaundice, and also ammonia. Pancreatitis is going to be kind of relative to that amylase and lipase increase, and then albumin is going to show some liver issues, but it's really going to show that malnutrition in your patients. Albumin, kind of remember the same as potassium, 3.5 to 5. So know your labs. All right, just some general GI diagnostic procedures. We're going to focus on the colonoscopy and EGD, but also know, and Ms. Petrarca may get into this a little bit with elimination, but your sigmoidoscopy and Your colonoscopies are going to be around, in the colon. The sigmoid is going to be more of that sigmoid colon down to the anus. There's no anesthesia with the sigmoidoscopy, but you still do the bowel prep just like you do for a colonoscopy. Your colonoscopy is going to look at that entire colon, and they are going to be sedated for that. And of course, the bowel prep. We want to get them nice and cleaned out so that when we put that camera up there, we're only going to see the colon and not everything else, right? So they really need to do that bowel prep and follow the instructions pretty good. EGD is coming from the top now, and EGD stands for esophagogastroduodenoscopy. That's a long word, but we're going to say EGD so that you know what it is. But again, it's going in through the throat, through the mouth, down the esophagus. We're looking at the stomach, and we're getting down to that duodenum. They do not need to do a bowel prep to that, but they do need to be NPO 6 to 8 hours before that, because they want that stomach nice and clean. We don't want to see the pills that they took that morning. We don't want to see any breakfast that they ate or the dinner they ate the night before, but we want that stomach nice and clean for us. Another one that you'll see them do that's going to check for ulcers, tumors, obstructions, things like that is a GI series. So basically they drink that lovely barium that's going to show up in an x-ray. They'll take a series of x-rays as that barium goes down the esophagus into the stomach, down through the duodenum and into the colon. They'll take pictures all the way through. It's important that they do the bowel prep with that. We want everything clear so that nothing's obstructing the x-ray views. But especially if there are obstructions or something, if it gets to the point where that colon or somewhere is obstructed, that barium's going to stop right there. So they're going to be able to see exactly where it is. If they have tumors or ulcers, it's going to fill in that ulcer or build in around the tumor. So they're going to be able to see different things within with that barium in the x-rays. Another important thing about a GI series is no smoking or gum. This can affect absorption of that barium. It can speed up peristalsis and all that and try and push it through a little bit more. So we want to keep a nice, normal, regular stomach, colon, all of that good stuff. And just a heads up to them that because of that barium, they may have some white stools for about a day to 3 afterwards. So that's not a shocker to them. All right, we talked about the EGD. There's that long word. Y'all have fun, say that 3 times, right? So again, it's looking down the esophagus to the stomach into the small intestine there. This is what they're going to use a lot of times when we get to peptic ulcer disease, diagnosing those ulcers, because they can actually visualize them. There again, pre-procedure, we just talked about that. They do use a little bit of local anesthesia, spraying down that throat to defer that gag reflex. It's pretty cool if you ever get to watch one of those. Post-procedure, again, they put that spray in there, so you want to watch that gag reflex before you start letting them eat, or they're going to choke on some stuff. They do complain of a little bit of sore throat. Also hear that too, if they've had surgery and they've had an intubation tube down there, it rubs on your throat, so a little bit of sore throat with that. And of course, when they come back from a procedure, we are always usually doing frequent vitals. So checking that temperature, checking their vitals every 15 to 30 minutes, making sure that we have no complications. If that scope goes down there, it can hit something, it can puncture something, and they could get a perforation and them not know it at the time. So we're watching for complications of that. Colonoscopy, again, visualizing all of that colon there. looking for polyps, tumors. They can diagnose diverticulosis. They can also go in and remove polyps, doing biopsies and all of that. Again, they have to do the bowel prep. They have to be NPO. They really want you to have those clear stools before you come in that make sure everything's cleaned out. After the procedure, they may have some abdominal cramps. They do inflate a little bit. They put some air in there to inflate that colon so that they can get a good view. And so, of course, they're going to have a lot of passing gas. And so that's a good thing. Again, we're observing for any complications, so looking for any bleeding. If they grab them polyps, you may have a little bit of bleeding, but they usually try to cauterize those so that they're not. And we want to look again for perforation to make sure we didn't injure that colon at all. Peptic ulcer disease is basically an erosion in the mucosa. You can have ulcers in the esophagus, in the stomach, down into the duodenum. Many times they're caused by this bacteria called H. pylori. That's the most common. We always say, watch those NSAIDs. Don't overuse those NSAIDs. We don't like chronic use of NSAIDs because they can cause ulcers. Stress can cause ulcers as well. Risk factors over here, smoking and alcohol. Go figure. Genetics can play a part in that. Again, those chronic NSAID uses. So, how do we know if it's gastric versus duodenal versus esophageal? If you think about it, gastric and duodenal. So when you eat, your stomach, it hits your stomach first, right? So you're going to have a pain that comes pretty quickly, about 30 minutes to an hour after eating. They may notice some weight loss because you're not getting that absorption the way you should. And it's going to be a dull, gnawing, burning sensation kind of in your back or the mid-epigastric area. And it's worse during the daytime. Whereas duodenal, it's made it through the stomach. It's been able to absorb everything it needs to absorb, so they don't notice that weight loss as in gastric. And it takes a little bit longer for it to absorb, do its thing in the stomach and get into the duodenum. So your pain is going to occur a little bit later, about 2 to 3 hours after meals. And also, if you think about them eating dinner and going to bed, it's going to wake them up at night. They're going to have that pain at night. And a lot of times with that, if they eat, a lot of times it kind of temporarily relieves that pain, but then it comes back again. So that's the difference between the gastric and the duodenal. Just a little picture. I'd probably print this one out, put it on my wall and study it because it kind of breaks everything down with your gastric ulcers, what we just talked about, when the pain occurs, the risk factors over there. Look, you got that man smoking right there. And he's looking at his watch, so you kind of know with the time, your gastric ulcers are going to hit before your duodenal ulcers. Your duodenal ulcers are a little bit more common. They are typically more well-nourished, like I said, because it's had time to do its thing in the stomach. Over there with your stress ulcers, it kind of talks about different things. You can have the physiological stress that causes the ulcers. Cushing's ulcer or brain injury can cause that. Curling's ulcer, they'll have with extensive burns. So just kind of print this out. Really pay attention to the gastric, the duodenal, and the common risk factors. So a little bit about stress ulcers. Pretty much it's not psychological stress, but it's more a physiological stressful event, such as burns, shock or severe sepsis. Totally different from peptic ulcers. So we don't even really focus on stress ulcers right now. All right, so how are we going to diagnose? If we have any bleeding ulcers, you may see some anemia in their CBC. Earlier, we talked about some of the liver function tests like your ALT, AST, your ALK Phos, some of your pancreatic enzymes, like your amylase and lipase. And I'll fix this slide for you guys. They can do a CT scan, or we can do that EGD like we talked about. And down here, it's just a rule of thumb. Usually we start with the least invasive first. So we'll look at our labs. What is that leading us to? Then we may do the CT scan. What is that telling us? If that doesn't show us anything, then the EGD is going to be a little bit more invasive than the other ones. How are we going to treat it? So we have antibiotics. If we find that bacteria in our stomach or around the ulcers, PPIs, proton pump inhibitors, that keeps that acid production down in the stomach. We can do H2 blockers, which blocks the histamine. And that histamine is what triggers that acid production in the stomach. Bismuth salts is going to coat. It's going to be a real good coat over the stomach. It's kind of like an external protection from that acid and everything eroding in the stomach. And then cytoprotective agents to inhibit that gastric secretion and promote the healing. So it's keeping that gastric secretion down so that those ulcers have time to heal. So what medications are these? So your PPIs are your prazoles. So pantoprazole, we see a lot in the hospital. Omeprazole, we see a good bit. Esomeprazole and lansoprazole. You may recognize the brand names, Nexium, Prevacid, and Prilosec. Again, those reduce the stomach acid on the parietal cells. The H2 blockers are your titines, famotidine, ranitidine, and cimetidine. You may recognize Pepcid, Zantac, and Tagamet. This is going to decrease that hydrochloric acid that stomach produces to break down food and things like that. Antibiotics, we're usually doing clarithromycin plus amoxicillin or metronidazole. So you're usually doing more than one to get that H. pylori. Your bismuth salts, again, coats it. It protects it from the acid. We usually use these with the antibiotic, and that's kind of like your Pepto-Bismol. Cytoprotective agents will promote that mucosal healing. So misoprostol, sucralfate. We do a lot of sucralfate in the hospital. And it's usually a bigger tablet that they take, and it kind of, you do it before meals so it has time to coat that stomach to help those ulcers heal by coating that stomach and keeping that acid from hitting on that stomach and eroding that stomach lining. Antacids, I know we've all had history probably with antacids. So your calcium carbonates, Tums. This is kind of used to neutralize the stomach acid. One big thing with antacids is we do not give with other meds, and we do not give with meals. So typically with your antacids, they're going to be an hour or so after your meals. And with your other meds, you want to make sure you're either giving it an hour before or an hour after with your other meds, because they're real sensitive with any other medications. They can have adverse effects. So with those with peptic ulcer disease, they're going to eat their 3 regular meals a day. You don't want them doing smaller meals multiple times a day because that's going to increase that activity in the stomach and increase your chances of your ulcers not healing or causing more. We want to limit things that are acidic like coffee, caffeine, and alcohol. Avoiding those extremes in food, very, very hot or very, very cold, because those like to stimulate the activity in the stomach and then cause that acid production that's going to cause problems in the stomach. Avoiding those NSAIDs, you know, we don't like those chronic NSAIDs, but if they have ulcers, those NSAIDs are going to do nothing but make them worse. We talked about antacids, and they need to make sure, you know, we're looking for complications all the time. So if they have those bleeding ulcers, you may notice some bleeding or tarry stools. And of course, stop that smoking. That smoking gets everything going again in that stomach and makes those ulcers worse. Surgery is not usually needed, and it's usually only recommended for those that have tried and failed to heal those ulcers. If they have any hemorrhages or perforations or obstructions, that's when they're going to go into surgery to help fix those. So complications. Again, we talked about bleeding. So if they have an intestinal bleed, you may notice blood in the vomit, blood in the stool. If it's an upper GI bleed, you may notice those black tarry stools. It may not be bright red blood, and we do what's called a hemoccult stool, where it's checking for that blood that you can't visually see in the stool. So again, this is another reason why we're doing vital signs, because you can see early on that heart rate's going to go up, the respiration's going to go up, but that blood pressure might still be normal. So if you're seeing a trend of that heart rate and respiratory rate going up, we might start suspecting some bleeding. Later on, that blood pressure is going to start to drop, and that heart rate's going to continue to rise. So when you see a rise in the blood pressure, a rise in the heart rate and a decrease in that blood pressure, you're thinking of some type of shock. If you think that your body is bleeding, so that heart's pumping harder and faster to try and replace that blood. And again, everything's going to open up, so that blood pressure is going to drop down. Perforation is a medical emergency. We need to be very vigilant on watching these patients. So if you see any changes in the abdomen, any distension, the big words that we're looking here is rigid board-like abdomen for perforation. So that abdomen is going to be tight, tight, tight. And again, this can quickly turn into peritonitis. Your patient is going to complain of sudden, severe, sharp upper abdominal pain. It may radiate up to the shoulder, and you're going to see those vital sign changes just like over here with internal bleeding. So that heart rate's up, respiratory rate, and that blood pressure is going to start bottoming out. So we need to catch this before it turns into peritonitis. All right, so that was PUD. Now we're going to go into GERD, gastroesophageal reflux disease. Again, very, very common. Basically, those gastric contents, those enzymes in there are kind of backing up into the esophagus and causing pain and injury into that esophagus, which can lead to Barrett's epithelium, which are cells that line the esophagus, where the cells become mutated from that recurrent exposure to the stomach acid, and they're more likely to become cancerous with that Barrett's epithelium. All right, so factors affecting that pressure. So here is your lower esophageal sphincter right here. So if that's weak, then it's not doing its job and it's letting this acid come on up in here, right? So a lot of things that make it worse: alcohol, chocolate, there's different medications, those fatty fried foods, smoking, the peppermint spearmint, pregnancy. You hear a lot of pregnant women get that, what they call heartburn during pregnancy, and of course, caffeine again. A lot of these things are going to increase that acid, which is then going to back up into the esophagus. So with GERD, they can get esophagitis. A lot of times with ulcers in there. We talked about Barrett's esophagus. And again, you may notice some respiratory stuff. You may notice a cough. They may get those bronchospasms. And all of that's due to those gastric secretions irritating that upper airway. And as you can see over here on the other side, the picture on the slide, again, there's an ulcer formation, and you can see the difference between your normal esophagus versus that Barrett's esophagus. You see how that Barrett's is just, it just looks raw and painful and pretty nasty. All right, so what diagnostic study are we going to do? What looks into the esophagus and the stomach into the duodenum? That's your EGD again, right? And when they're doing this EGD, they're not only looking to see if you have any ulcers or wear in the linings there, they're also going to look at that sphincter, the lower esophageal sphincter, and see if it's weak or if it's strong or if it's doing what it's supposed to be doing or not. So somebody with GERD, we're going to tell them that they need to sit up after their meals. They don't want to lay down, because when you lay down, you know, gravity, it can increase the chances of that acid going up into the esophagus. Again, don't smoke. Everything. I don't think smoking helps anything ever, I guess, except for bad habits. Drug therapy, we're going to use those PPIs and H2 blockers such as pantoprazole and ranitidine. We can also use antacids, which are usually kind of a quick fix, but it doesn't continue to help. It's kind of a short-lived relief there. And again, be mindful when we're giving antacids not to be giving them with other medications. They also can prescribe the metoclopramide, or another word, the brand name is Reglan. This medication is going to help accelerate that gastric emptying, so it doesn't have time to go back up into the esophagus, right? So we're going to try and push everything through. There's really no specific diet for GERD, but of course we want to avoid foods that trigger it, right? Avoid eating late, because then we're going to go lay down afterwards, and there goes that acid up into the esophagus. Again, surgery reserved for any complications. They may have to go in there and help reinforce that sphincter. Fundoplications are common laparoscopic anti-reflux surgeries, where they kind of wrap the fundus of the stomach around the esophagus to help get that extra support in there. But they don't really do those very often unless we're having any complications. All right, so a good idea for you to do is to sit down with this Venn diagram and put in everything you know about PUD, everything you know about GERD, and see what the common themes are between the both. Because if you know it all and you can distinguish, you know, PUD from GERD, you'll be able to answer questions better on the test between the two. Upper GI bleed. So again, we talked a little bit about this, about hemorrhages from peptic ulcer disease, and PUD is the most common cause of your upper GI bleeds. Patients may come in talking about their stools are dark and tarry, and this is called melena. So if you hear somebody talk about melena, you're talking about those dark tarry stools. Again, you know, is with the upper GI bleed, it has time to get through all of the intestines, and it kind of helps that BM look more dark and more like tar. And it has, if you've ever smelled a GI bleed, you'll never forget that smell. It's a very distinct smell, and you can pretty much diagnose it from the smell of their stools. Think about upper GI bleed when they're vomiting. It's up top. It doesn't go through all the intestines, so you're going to have bright red or sometimes like dark coffee ground looking vomit. And again, that dark coffee ground looking appearance is due to that oxidation of the hemoglobin. They may complain of nausea and vomiting. You think about that blood being up in your stomach area, it definitely doesn't feel good, right? And of course, losing blood and decreased hemoglobin, they may complain of dizziness or even sometimes fainting. We talked about vital sign changes. What's that heart rate going to do? It's trying to compensate for the body losing blood. So it's going to pump a little bit faster, a little bit harder. Those the circulatory system is going to open up to be able to deliver that blood everywhere, so your blood pressure is going to drop down. So how are we going to treat this and diagnose it? So diagnosing, a lot of times we catch it on their CBC where we see their hemoglobin hematocrit shows an extensive blood loss. That's going to be your first step. They're going to do a CBC first, and they're going to see that that hemoglobin hematocrit are low. Then sometime after that, they're going to get you admitted. They're going to start you on PPIs. They're going to NPO you. And within 24 hours, they're going to do that upper endoscopy, which is your EGD, so they can scope and see where that bleeding is coming from. So first line of diagnosis is your CBC with the hemoglobin hematocrit. Then we're going to move on to the EGD to kind of confirm it and locate the source. Again, we're going to start those PPIs for your acid suppression, and those are going to be IV. They're not going to be PO. They're going to give that stomach a rest until we can figure out what's going on with them. So what are we going to do as nurses? Many times you're going to throw an NG tube down them, nasogastric tube. So in through the nose, down into the stomach, right? This is going to help kind of keep some that blood or anything out of the stomach. If they are bleeding in the stomach and it's getting a lot of blood, you may have to kind of flush through that NG tube to help keep it clear from clots and things like that. A lot of times this will help prevent that nausea and vomiting from the decompression of those gastric contents. We talked about a Hemoccult stool, but they're going to do that again to make sure to see if we have blood in the stool. Typically, we're doing on a normal patient every 8-hour vitals. This patient is bleeding. We need to do eyes and nose frequently. Usually we're doing those every hour. That way we can catch things early. We can see how much they're bleeding, if they're vomiting, all about that. All right, so a little fun fun little slide here about intestinal bleeding. You can have bleeding from your esophagus called esophageal varices. We'll kind of hit on that when we talk about hepatitis. Of course, they can have bleeding in their stomach with ulcers. Same with their duodenum. In the lower GI, you can have polyps. IBD can cause some down in the jejunum. Same with the ileum. Diverticulitis a lot of times in the colon. So a little fun picture for you to kind of look at. So now gallbladder. Some of you may have already had issues with your gallbladder and could probably tell us more about it than those who have not, right? So the gallbladder is going to be the major function of it, storage for bile. And bile kind of helps break down things throughout the body. That's kind of your diagram. Oh, it turned on me all of a sudden. So we're going to talk about cholelithiasis and cholecystitis. So chole is going to be talking about your gallbladder. Lithiasis is going to be the stones, and cystitis is going to be the inflammation. So cholecystitis is that inflammation of the gallbladder. Again, another little fun picture. We like those fun pictures. So they may come in complaining of some fever. Leukocytosis, what is that? That's the low white blood cells, right? I take that back. That's going to be your sorry, I had a message coming through, but that fever and leukocytosis, like leukocytosis. So think infection. So with infections, we have fever and we have that high white blood cell count. So that's what leukocytosis is. We're going to have that jaundice. I love how they turn her hair yellow because she's jaundiced. Jaundice is a result of that bilirubin breaking down with the bile having issues going through. It's going to build up in the body and cause that yellowish appearance. Those who have had issues with their gallbladder, a lot of times you get a lot of nausea, sometimes vomiting. They may not want to eat because when they eat, it kind of makes it worse. This is where they're going to have that pain in the right upper quadrant or kind of radiate up into the right shoulder, sometimes maybe even to the back. And that pain is going to get worse with that increased deep breath. They're going to feel bloated. They're going to feel that feeling of fullness after they eat. They may have some distension in the abdomen. Cholelithiasis. Again, the right upper quadrant pain, may even be in the epigastric pain. It's kind of colicky where it kind of comes and goes. May radiate up to the shoulders area. And again, nausea and vomiting. With cholecystitis, you may hear that Murphy sign. It's that pain up in that right abdominal area where the gallbladder is. And when you get, when they're palpating that, it radiates up with inspiration. And then a fever and chills, of course. All right, so symptoms, again, we talked about very similar to cholecystitis. Depending on where those gallstones are, it can block that common bile duct. If we have any blockages within that bile duct, you may notice an increase in that amylase and lipase. Also with your AST, ALT, it can cause that bilirubin to go up as well as your ALP phos. And when that bilirubin goes up, you're going to see that jaundice appearance. So that's basically that liver not being able to get rid of the bile because of the obstruction. So how do we diagnose this? A lot of times they'll do an ultrasound and take a look at that gallbladder. They can see stones, they can see sludge, they can see inflammation, all that good stuff. They could do an x-ray, a CT scan, which the x-ray is not going to show too much. CT scan will show a little bit more than the x-ray. And then they can do that ERCP, which is the endoscopic retrograde, another long word, cholangiopancreatography, where they actually go in and they visualize those biliary structures in the pancreas, kind of like the EGD with the scope on the end. How are we going to treat this? Many times, your symptoms they're either asymptomatic or they kind of come and go. They don't really require medical management or hospitalization. If the patient's symptomatic or has an obstruction, again, they can go in and do that ERCP to remove those stones. And more often than not, y'all will hear about them getting cholecystectomies, where they actually, they can do it laparoscopically, or they can do open up the abdomen and get them out that way. Most of the time these days, they're going to do a laparoscopic. All right, so here's your laparoscopic here. You're going to have 4 different little inserts where they'll insert the camera and their instruments to go in to get those stones out. Open surgery, they're going to have that incision, that surgical incision there that you will have to take up. And the Da Vinci surgery is where they actually just go in through the navel and break up those stones. So more than likely, you're going to see the laparoscopic cholecystectomy. All right, so what do we have to do? We're the ones taking care of them after surgery, right? So we want to give them pain medications, get them up and ambulating. Many times they put air into the stomach and it causes a lot of cramping and stuff like that. So a lot of times, most of their pain is from that. So getting up, moving, getting that air out, that's going to help a lot with pain. Using a pillow or splinting, especially when they're doing their coughing and deep breathing and stuff like that, so they don't hurt any of their incisions. We talk extensively about turn, cough, deep breathe, incentive spirometer, getting up, walking, SCDs, what else? Turning, early ambulation, all of that to prevent complications from surgeries. Typically after a cholecystectomy, especially if they've had an incision, you're going to have a T-tube in place. So you're going to have to know how to take care of that T-tube. Sometimes they'll even put JP drains in. So you're going to have to drain and keep up with drainage from that and take care of your incision site for those. Uh-oh, it backed up on me. Previous. So nutritional status, pretty much back on a normal diet. Stay away from the high-fat foods, a good healthy diet. So low-fat, high carbs, and proteins immediately post-surgery. Again, once they're home, a nice healthy diet, avoiding those fatty foods. And 4 to 6 weeks, they can resume a normal diet. Complications after most surgeries is going to be bleeding or hemorrhage, right? And we've talked extensively now about hemorrhages and bleeding and what the vital signs are going to do. So we're going to watch for excessive bleeding through any surgical sites, doing that GI assessment, making sure we don't have any perforations or anything. So what is the abdominal perforation? That rigid, tight abdomen, abdominal distension, your tachycardia, your increased temperature, all of that is going to be your perforation, which is a medical emergency, and we need to contact the doctor ASAP. All right, so they don't need to go out there lifting weights again. Light exercises, avoid lifting anything greater than 5 pounds for a couple weeks. If they've had an open surgery, it may be a little bit longer than that. If they have a laparoscopic procedure, they can shower a couple of days after. With an open procedure, maybe a little bit longer, just because you don't want bacteria and stuff getting into their surgical sites. Watching those surgical incisions for signs of infection. Don't be scrubbing on those laparoscopic sites. Kind of let the Dermabond, is which they use to close those sites, kind of don't peel them off or anything, just let them do their thing. Pain medications as needed. Again, we talked about that air pain in their chest from the surgery, and this is going to be normal. We need to get you up walking, getting that air out of you. All right, now going into obesity. Big thing with obesity is just being very sensitive. Your BMI is going to be 30 or above. So anything 30 and above, they're going to be considered obese. So we really don't want to get hung up in all the details with all the surgeries and everything, but we're going to kind of go over some hot spots that you need to know. We all know that obesity increases hypertension, your chances for hypertension, diabetes. Fun fact, you're twice as likely to be diagnosed with Alzheimer's disease. So, you know, obesity just kind of increases your risk for a lot of comorbidities. Of course, you know, we talk about this all the time, a good diet, exercise. All adults should be having at least 150 minutes of moderate intensity exercise. So let's say walking 30 minutes, 5 days a week. So that's 150 minutes, a good brisk walk. How about 75 minutes of vigorous intensity exercise a week? Addressing barriers to change. What's causing you to overeat? What's stressing you? Let's figure out what your barriers are to where that you're having issues losing weight. Improving your diet habits, giving them types of diets they can follow, and it is pretty much a lifestyle change. I mean, you know, convenience of fast food and, you know, working and it is pretty expensive to eat healthy, honestly. They do have medications that they can take, but those are meant to be supplemented with changes in their diet and exercise. And these medications have some severe side effects. If you're eating fatty foods or anything like that, could cause severe diarrhea, nausea, vomiting, all that good stuff. So just to be on the lookout for that. Complications, they can get that obstructive sleep apnea, hypertension, increased risk of DVTs. You've seen a lot of times where they have venous stasis and their legs look really bad at the bottom, pressure ulcers, skin breakdown, yeast and things within folds of the skin, that kind of stuff. be sensitive to these patients. A lot of times, you know, they're going through a lot, and if they feel like they're going to be judged going in somewhere, they may not go in. They may not report things just because they don't want to come in and be laughed at or criticized or looked down upon because, you know, they can't control their eating and things like that. So there is a stigma with a lot of patients, and we need to be respectful and courteous and empathetic to them. You need to come to your own terms about your beliefs and attitudes about obesity, and really try to get any bad thoughts of that out of your head. I had an aunt that actually went through bariatric surgery, and she had a difficult time. It's very hard. That surgery is not an easy surgery, and especially afterwards. When I first started LMC, I was on the bariatric floor for one of my rotations, and they're miserable after surgery. They are nauseated, they are throwing up, they are sick. Anything they put in their stomach is coming right back up. They can only drink like a little tiny medicine cup of water, eating a tiny amount of food, and it's, you know, it's not glorious. So, and if anybody in here's ever been through the surgery, they can attest to that. It's not a fun surgery. So talking about surgeries, again, we're not going to get really bogged down with all the specifics of everything. Basically, your after surgery is what's going to be the most important things for you to really focus on. They're not just going to updo surgery on anybody. Different factors they look at is your body weight, your history. You have to have a support system. Many times they have to go through some type of counseling before the surgery. They have to try to lose weight before surgery. And they have to be able to perform ADLs in their own safe care and their own self-care. Of course, there are extenuating circumstances where they're not going to do surgery. So if they have some type of endocrine disorder, they may defer surgery. Cushing's, for instance, it causes obesity. So they're not going to go in and do all this invasive procedure knowing that this Cushing's disease is going to just turn around and make you gain more weight. They won't do surgery if you're abusing drugs or alcohol, or with severe psychiatric illnesses. They want to try and get all that treated before they attempt to do this invasive procedure so that they can be successful. All right, so if all of them kind of know the Roux-en-Y gastric bypass here, it's where they pretty much staple up your stomach right up here. They kind of take your jejunum here, and they do a stoma up here. And so they're leaving all this in there. They're leaving all this there, but this is your stomach, this little bit of piece right here. And so everything's feeding down here into your jejunum and going down into your intestine. So all this right here is not doing anything. Gastric banding, I think that's a very common one. It's least invasive, where they put a band around there to kind of make that pouch. And, you know, you have some food coming in here, but not as much. So you'll be able to feel fuller with this little pouch to stop eating. And at different times, they may have to go in and tighten it up a little bit. And they can loosen it up as well if need be. The gastric sleeve, where they cut out all the stomach. And so all you have is, it looks like a sleeve. It's just this little sleeve right here of your stomach. Then this whole big old gastric switch thing here. So they're going to cut up your stomach, make us leave, and then they're going to disconnect you from your jejunum and put it directly into the ileum, going all down into your intestines there. So it's a lot going on. So what are we going to do with these patients after surgery? We're going to make sure that they're not in pain. We're going to maintain their fluid balance, prevent infections, making sure that they're adhering to their very, very restrictive diet restrictions. Talk about supplements. They are going to need lifelong follow-up with this. Help them achieve that positive body image and maintain normal bowel habits. So after surgery, there's going to be a very slow progression from clear liquid to full liquid to a soft diet to regular. So what types of food are on clear liquids? Again, it's just what it sounds. If you can see through that liquid, like Jell-O, what else? Basically, if you can see through it, that's a clear liquid. I can't even think of anything else right now. But basically, they're going to go home on that clear liquid diet. We're going to make sure that they're tolerating liquids first before we discharge them. And they're going to go several weeks and then do a full liquid diet, which will throw in oatmeal and grits and a little bit thicker substance. And then they're going to progress to a regular diet. If they're having any leaks or anything, you may notice fever, abdominal pain, increased heart rate, increased white blood cells, and all of that can lead to sepsis. Diarrhea is very common after bariatric surgery, so we want to make sure we have a control over that. Of course, constipation can be caused from general anesthesia and pain med use. So they may be placed on DocuSate if they have constipation. Again, adequate nutritional status. So once our bowel sounds have returned, then oral intake is resumed. They are going to do 6 small feedings of about 600 to 800 calories per day. So they're not going to sit down 3 times a day and eat a big meal. They're going to do tiny feedings throughout the day. They must eat slowly and they must stop when they're feeling full. The registered dietitian may be consulted and they may need some extra iron supplements or B12. Another thing too with them, and it might be in another slide here, but we're not letting them, you should not let them drink liquids with their meals. So if they're going to have liquids like water or anything, it's going to be restricted to 30 mLs at a time. And we don't do that with their meals. It has to be in between meals. Again, eat slowly, chew slowly. It should take about 30 minutes to an hour to eat their meals, avoiding milk, sweets, high sugars, any of those empty calories, because, you know, our stomach's only so big now and we need to fill it with what's important. Complications, I think, again, surgery, hemorrhage. Dumping syndrome, we're going to talk about in just a second. Dysphagia, not being able to swallow, and obstructions. No, they're not going to have NG tubes after surgery. The NG tube may disrupt the surgical suture line and cause that anastomotic leak or hemorrhage. So no NG tubes, even if they're nausea, vomiting, anything like that. You know, a lot of times we'll throw an NG tube down to decompress. We are not doing that with our gastric bypass surgeries. We don't want that tube to damage anything in the stomach. So a big one that you're going to have to know for surgery is dumping syndrome. It's pretty much their stomach is not as big. And sometimes that food can rush through the stomach a lot faster than normal. And so then it's dumped into that duodenum. And that's where it's going to start being absorbed. And that's not where things are supposed to be absorbed. So your body gets kind of wonky and it doesn't like that. So you may notice sometimes 15 minutes to 2 hours after eating, their heart rate go up. They complain of dizziness. They have that sweaty feeling, nausea, vomiting, bloating, abdominal cramping, and sometimes diarrhea. If you notice anything like this, it's we need to recognize that right away. And we need to let the doctor know. So later on with that dumping syndrome, you know, since it's gone through the body, the stomach so fast, your blood glucose can rise rapidly. And that blood glucose goes up, your body's going to produce that insulin secretion. So you're going to have that reactive hypoglycemia. This is going to be about 10 minutes to about an hour and a half after. Again, think of your hypoglycemia, that pallor, that perspiration, these heart palpitations, headache. They're feeling warm, dizziness, and drowsiness. Another little fun slide that you might want to hang up on your wall. So about dumping syndrome. So as you can see, we're getting up here and dumping that food in, right? So as it's coming over the edge, you're getting nervous, get a little sweaty, that pulse is going up. You start having diarrhea because of that increased peristalsis and that abdominal distension. So down here, you want a low carb, low salt, low sugar diet, low volume, low water, dry meals. We don't want a lot of water filling up that stomach. And very important if, you know, to prevent this dumping syndrome. Whereas GERD, we want them to sit up afterwards. With gastric bypass, we want them to lay down. That laying down will help keep that food from rushing through that stomach because of gravity. So have them lie down after their meals. All right, so something to think about to help you with this is think about what are some priority nursing diagnoses for peptic ulcers, for GERD, for bariatric surgeries, post-surgicals. What are we going to do to prevent complications? All that stuff. So if you fill out your little concept maps on a patient with PUD or GERD or gallbladder or bariatric surgery, it'll help you start prioritizing your plan, your interventions, and what you need to do to help prevent those complications. All right, so again, this is Ms. Coates. That was our nutrition lecture. I hope you found it enjoyable. I will post this up for you guys, and if y'all have any questions, please reach out to me and I will get them answered for you. Everything that you need to know for the test is going to be within these PowerPoint slides. And if you have any questions, you can refer to your book for clarification. And if you have any questions after that, it's still not clear, please reach out to Ms. Coates. And I hope y'all have a great day.